who will need thromboprophylaxis. So the title of my talk is Anticoagulation in Women with Recurrent Miscarriage. Yes, please. Next, please. Uh, in a systematic review to assess risk of miscarriage in women, it has been said that every pregnant woman who has never experienced pregnancy before carries a risk of about 11% of having a miscarriage. This means from 9 women who will call you or you know that they are pregnant, one of them will miscarry. Okay. And this is normal. If a woman have one previous miscarriage, so the risk goes up to 17%. It might not be statistically significant, but when women with previous 2 miscarriages, okay, and she's now pregnant, the risk jumped to up to 30%. Okay. And if a woman experienced 3 previous miscarriages, it has a 40% chance of having miscarriage. This means from 10 women with previous 3 miscarriages, 4 of them will miscarry again. And the risk could be almost 50% if she has 4 previous miscarriages, and the risk could be up to 65% if she has experienced 5 consecutive miscarriage. So next, please, Mr. Sameh. So, why do you think I have presented the previous slide? Just to let you know that having one miscarriage, sporadic miscarriage, is quite something not unusual. It's very common for anyone working in obstetrics to see a woman who is pregnant and then she miscarried for once. Okay. And the chance of having a healthy baby in subsequent pregnancy up to 90%. So, not always all women who have one previous miscarriage need thromboprophylaxis. What we are seeing in our country now is that there is abuse of thromboprophylaxis. Each time you see one pregnant woman and she said, "I have a previous miscarriage," at least she will have aspirin or salicylic acid, and some women take it further. Some doctors take it further to fractionated or unfractionated heparin, and some may take it further and they give even corticosteroids. And I don't know what's the justification of this, other than it's some kind of defending yourself that if she had the 10% chance of miscarriage or the 17%, then you say, I did what I have to do. But I am trying to remind you that you are abusing a very powerful tool. Now, let's go to our first case. This is Mrs. Fatima, who's 30 years old. No, Mr. Samah. Yes, she's 30 years old. Okay. She got previous 3 miscarriages. As for her first pregnancy, it was ended 5 weeks immediately after the intrauterine sac was detected. And this is before detection of fetal pulsation. Second miscarriage occurred at 12-week gestation, definitely was fetal pulsation. And the third one was intrauterine fetal death at it was 10-week gestation. This lady was subjected to antiphospholipid antibodies assessment, and it turned out to be positive. Lupus anticoagulant was negative. No family history of consanguinity. TSH was normal. 3D ultrasound reveals normal uterine cavity. Next, Mr. Samah, please. So let's go through this case. For definition, now, yes, this is a case of recurrent miscarriage. Why I'm saying this? Because she has 2 or more consecutive miscarriage. And according to the ASRM and the ISHRI, now 2 miscarriages, 2 consecutive miscarriages or more are now considered recurrent miscarriage. Although the RCOG still considered 3 or more consecutive miscarriages. But now we are speaking about a case of recurrent miscarriage. What's the etiology? This is antiphospholipid syndrome. It's an autoimmune disease. And what's the clinical feature? Why would you say this is antiphospholipid syndrome? This is because there is three recurrent miscarriages. One of them was after 10 weeks gestation, and antiphospholipid antibodies was positive. And let me remind you that we need to repeat antiphospholipid antibodies after 3 months if we have one positive result to confirm the diagnosis. So, what's the suggested treatment? It's giving low molecular weight and aspirin in subsequent pregnancy and to be started immediately after a positive pregnancy test. And this has to continue throughout pregnancy. Next, please. Now, we go through antiphospholipid syndrome. What's this antiphospholipid syndrome? This is one of the most treatable causes of recurrent pregnancy later. It is responsible for about 20% of women with recurrent pregnancy loss. So one of each of five women who experience recurrent pregnancy loss would be due to antiphospholipid syndrome. And not only this, but women with antiphospholipid syndrome are at higher risk of developing preeclampsia and fetal growth restriction, as well as preterm labor. Yes, please. Next. There are some clinical criteria and laboratory criteria to confirm the diagnosis of antiphospholipid syndrome. We all know the clinical criteria. It is having one intrauterine fetal death after 10 weeks gestation or three consecutive miscarriages below 10 weeks gestation, plus having an event with preterm labor at 34 weeks gestation due to severe preeclamptic toxemia or with fetal growth restriction. This has to be combined with laboratory criteria as regard anticardiolipin, IgG or IgM, and lupus anticoagulant or anti-beta 2 glycoprotein IgG, IgM. One of these criteria has to be positive, and if you found it to be positive, you have to repeat it after 3 months to confirm the diagnosis. Next, please, Mr. Sameh. Now, I told you that if you are encountered with antiphospholipid syndrome, so all you have to do is to give aspirin and heparin in subsequent pregnancy. And from where this evidence came from? It came from the Cochrane. Cochrane has evaluated whether giving aspirin and or heparin or both for improving pregnancy outcome in women with persistent antiphospholipid antibodies and recurrent pregnancy loss. Next. Next, please. Yes. Can you see here? This is the main results of this meta-analysis. Okay. When they compare aspirin to nothing, it turns out that aspirin alone was not effective. When they compared giving heparin with aspirin, the live birth rate has improved. It improves by about 27%. This means there is an increase between 1.9 to 1.49. So the benefit between 7% and up to 50% increase in live birth rate. And this is absolutely fine. Next, please. Next. This is the meta-analysis. And as you can see, the first meta-analysis, the first black dot, it shows the giving unfractionated heparin plus aspirin. So the black dot high up, it is in the right side of the picture. This means it is much better than giving nothing. Okay. Sorry, it's much better than giving aspirin alone. In the lower part, if you give low molecular weight heparin plus aspirin, it's also much better than aspirin alone. If you combined those trials who give aspirin and fractionated heparin versus aspirin alone to those who give low molecular weight heparin plus aspirin, the net result will be much improved in live birth rate. And you all know that the difference between low molecular weight heparin and unfractionated heparin. We are always now giving low molecular weight heparin, but because in meta-analysis, we usually combine trials from different years. So some years before, unfractionated heparin was the only available heparin. So we combine these results together. So we reach the conclusion that if you have a woman with recurrent miscarriages and one of the antiphospholipid antibodies was positive together with clinical history that suggests antiphospholipid syndrome, so all you have to do is to give aspirin and low molecular weight heparin as soon as you discover a positive pregnancy test, and this has to be continued throughout pregnancy. And by that way, you are increasing the chance of having a live birth. Yes, next, please, Mr. Sam. Next. Uh, this is slide represent the difference between heparin and aspirin versus aspirin alone in minimizing the pregnancy loss. And as you can see, the black dots are on the left side of the picture, and this means that giving heparin and aspirin leads to decrease the incidence of pregnancy loss, and this is good. Next, please. Next. Now, let me conclude to you case scenario one. Case scenario one about a case of recurrent miscarriage. And what we know now, you have to make sure that this is a case of recurrent miscarriage and this has a antiphospholipid syndrome, which is acquired thrombophilia problem, and the treatment of it will be by heparin and aspirin, not aspirin alone. About the case scenario, second case scenario is about Mrs. Ilham, who's 25 years old, and she experienced first pregnancy has ended in 5 weeks immediately after intrauterine sac detected and before pulsation. Second, the pregnancy loss occurs at 11-week gestation. Third, the pregnancy was complicated by intrauterine fetal death at 28-week gestation. Anticardiolipin antibodies were negative, lupus anticoagulants was negative, rest of thrombophilia screening was negative, except factor V Leiden mutation heterozygous was detected. There was no family history of consanguinity, TSH was normal, 3D ultrasound reveals normal uterine cavity. Oh, yes, let's speak about it. Next, please, Mr. Sam. There is a very good guidelines released by the Royal College as regard recurrent miscarriage, okay, and how can you diagnose and what's important investigation in terms of what to do and what not to do. And this is about guidelines based on current evidence, okay. uh, guide, the RCG guidelines suggest screening for inherited thrombophilia. What's inherited thrombophilia? Inherited thrombophilia, we'll see in the next slide, carries like protein C deficiency, protein S deficiency, antithrombin deficiency, as well as factor V Leiden mutation, prothrombin gene mutation. Those are what we call inherited thrombophilia. The Royal College suggests that women with such events or and recurrent miscarriage may be offered testing for factor V Leiden mutation, prothrombin gene mutation, protein S deficiency. This is in contrast to other inherited thrombophilia like protein C, antithrombin deficiency, and what they call methyl tetrahydrofolate reductase mutation. It is not recommended testing women for this kind of inherited thrombophilia because according to current studies and current literature, there is very weak association between this kind of inherited thrombophilia, those namely protein C, antithrombin deficiency, and methyl tetrahydrofolate reductase mutation, and the occurrence of recurrent miscarriage or second trimester loss or intrauterine fetal death. So it is not recommended to do those. Next slide, please. Uh, If a woman have inherited thrombophilia, this increase the risk of having thromboembolism during pregnancy. And if she is pregnant, this is another inevitable risk. So the combined risk has led to an elevated risk of PTE. And as Professor Yasser Kassar will show us in next talk about guidelines, how to deal with the guidelines in providing thromboprophylaxis for those women, you will find out that you have to give thromboprophylaxis for those women. But let's stick to our talk and Mrs. Ilham, who's now have previous bad obstetric histories in terms of recurrent miscarriage and one intrauterine fetal death at almost the end of the second trimester or the third trimester. And now she is tested positive for factor V Leiden mutation. Next, please, Mr. Samah. Now, the Royal College has recommended thromboprophylaxis for this lady. Why? Because there is a lack of agreement about whether you have to give full thromboprophylaxis or not. In other terms, and I will show you that uh, uh, studies have shown has studies had shown conflicting data. Some are saying yes, there is a risk, and heparin and aspirin or heparin alone have decreased this risk, while other has not shown or and demonstrated this improvement and this benefit. So the recommendation by the Royal College is, owing to the lack of data, thromboprophylaxis could be considered for women with factor V Leiden mutation, protein S deficiency, and prothrombin gene mutation. This is as together with history of second trimester miscarriage. And be careful here. I'm now speaking about a woman with recurrent miscarriage. I'm not speaking about general obstetric, where in general population, and by some for some reason those women have done this investigation, and now you are assessing whether to give them thromboprophylaxis or not. I'm speaking about a case with recurrent miscarriage and one intrauterine fetal death, and one of these investigation has turned out to be positive. So according to the RCOG, they have to be given low molecular weight heparin. Next, please. These are the data I'm speaking about. It in 2004 there was an RCT that shown an improvement in live birth rate in women taking low molecular weight heparin and with history of single leg miscarriage after 10 weeks, and they are tested positive for factor V Leiden, prothrombin gene or protein S deficiency. Later on, another two RCTs have shown different data. One of them in 2011 and shown no difference, no statistical difference in giving women this kind of thromboprophylaxis. And the most recent one is in 2023, and they show no evidence of improvement in live birth, whether or not thromboprophylaxis was given. But the recommendation now are to give thromboprophylaxis. And the reason for this is, in most of these studies, they are recruiting almost women with whatever inherited thrombophilia. For example, they are recruiting women with protein S deficiency. They are recruiting also women with high risk inherited thrombophilia. So these studies are considered underpowered to detect an improvement in specific women with high risk of thromboprophylaxis. I mean, if you do a study and only recruiting women, for example, with factor V Leiden, you may have good results. But when you are recruiting women with low risk of thromboprophylaxis as well and then distribute them across arm, this may iterate the effect and doesn't show the beneficial effect. So until a very big trial that's is recruiting only women with high risk of having a thrombus or high risk of having VTA or inherited thrombophilia and bad obstetric history, we should continue to give those women thromboprophylaxis, and it's quite safe, and you are doing the right thing. Next, please. This is a systematic review that included the previous studies, but not the most recent one. And it doesn't show a benefit, as you can see, from giving heparin or thromboprophylaxis for those women with late miscarriage and positive inherited thrombophilia. But although this is the current available meta-analysis in the literature, it is now deficient because it is lacking one of the most recent randomized trials. Besides, those people who have who have who has put the guideline in the RCG have seen this meta-analysis, but although it's present, they prefer to give an advice to give thromboprophylaxis because the problem in these studies are not quite informative. Next, please. Again, there is no benefit. Next, please. Yes, this is the most recent study I told you about. It's just been released in 2023. It's speaking about giving heparin for women with recurrent miscarriage and inherited thrombophilia. This studies have shown no benefit of giving low molecular weight for women with inherited thrombophilia. تمام? As the live birth rate was equal across arms, whether to give or not to give thromboprophylaxis. But uh, having a detailed analysis of this paper have shown that they were recruiting women from, as I said, high risk inherited thrombophilia and low risk as well. Next thing is they were not giving aspirin or salicylic acid except for women with high risk of having preeclampsia. And as Professor Salah Abdul Rashid said, aspirin or salicylic acid is an antiplatelet agent. It is not interfering with the senses of clotting factors. That total number may be slightly small than needed for exploring the risk of high risk thrombophilia effect. Next, please. The third scenario is the most important one because in many times, like in Miss Dahlia, who is 23 years old, has 3 consecutive first trimester miscarriages, and you met her and asked for investigations. It reveals our TSH, prolactin, and thyroid peroxidase antibodies are normal. Karyotyping is normal for both her and her partner. Acquired thrombophilia screening is okay. Inherited thrombophilia screening maybe okay as well. 3D ultrasound revealed normal uterine cavity. TORCH was not performed, and here I am stressing that TORCH is no longer a cause of recurrent miscarriage. You shouldn't ask for rubella and cytomegalovirus for cases of recurrent miscarriage because actually women usually develop immunity against these kind of things if they catch it once, so it's not a cause of recurrent miscarriage. Next, please. Now, from where uh, we will get the evidence again from the Cochrane. Cochrane is speaking about giving empirical aspirin with heparin or without for women with unexplained recurrent miscarriage. And what's the evidence? Next. There was no benefit of giving low molecular weight heparin or and aspirin for those women. That means there is still the 60% chance of having or 70% chance of having a successful pregnancy, a live birth rate, whether or not you give aspirin and low molecular weight heparin. So please do not give those cases who you cannot find a cause for recurrent miscarriage, any heparin or aspirin. Next, please. So what we can provide to them? just support, give them progesterone, and even in the Royal College guidelines said if they bleed. But I would say there is no problem of giving them natural progesterone, and you may give antioxidant for them. And there is some growing trends of giving these antioxidants for those women, and this is flow risk. Next, please. Thank you very much for your presence, and I was happy to be with you. Thank you.